So we are going to discuss your patent ductus arteriosus. Patent ductus arteriosus, it is an acyanotic congenital heart disease. So it is a type of acyanotic congenital heart disease. And the other type of acyanotic congenital heart disease, we have discussed that in acyanotic congenital heart disease there is presence of left to right sound, that is ASD, VSD and PDA. So among these most common is VSD. Now we will discuss with PDA. We have discussed with ASD also. We will discuss with PDA. So in patent ductus arteriosus, it is mostly seen in case of preterm babies, greater than term babies, and is associated with congenital rubella syndrome. Patent ductus arteriosus is associated with congenital rubella syndrome, and here as we discussed there is present of left to right sound. So this part is called ductus arteriosus. It is present during fetal circulation and plays an important role in fetal circulation. So ductus arteriosus, it connects aorta with the pulmonary trunk. So ductus arteriosus connects aorta with the pulmonary trunk. After bath, it must close. The functional closure of the ductus arteriosus occurs after 10 to 15 hours after the bath, and the anatomical closure occurs by 21 days or 3 weeks. Anatomical closures occur by 3 weeks and the functional closure occurs by 10 to 15 hours. So what substance keeps the ductus arteriosus open? What substance keeps the ductus arteriosus open or patent? That is called prostaglandin. Prostaglandin make this keep this ductus arteriosus open. So they are responsible for patency of ductus arteriosus. We will discuss that more when we will go to the treatment part. So if the ductus arteriosus is patent, I told you it's a type of left to right sound. Aorta, it is connected with the left ventricle and pulmonary trunk connected with the right ventricle. So when the blood is shunted from the aorta to the pulmonary ventricle, it will lead to development of left to right sound. So as we know, there is high pressure difference present between aorta and pulmonary trunk. In the aorta, pressure is very high, in the pulmonary trunk pressure is low. So the blood is shunted from the left side to right side, and when this blood is shunted from aorta to pulmonary trunk due to high pressure difference, it will give a sound murmur. There is a characteristic type of murmur that is only heard in PDA. It is called machinery murmur. So loud continuous machinery murmur, it is heard in case of PDA. It is a type of sound murmur. In VSD we discuss pansystolic murmur, that is also a sound murmur. So machinery murmur, it is a type of sound murmur. It is mostly heard in the parasternal area of second left intercostal space. It is mostly heard in the parasternal area of second left intercostal space. So what will happen due to this? When the blood from aorta comes to pulmonary trunk and this blood goes to lungs, now there will be increased blood flow to the lungs. So now there will be development of pulmonary vasoconstriction and congestion of the lung with blood. When the lung is congested with blood, there will be pulmonary vascular remodeling. When the lung is congested with blood, it can lead to development of pneumonia also. And after some time, when there is chronic increased blood flow to the lung, there will be pulmonary vascular remodeling and hypertrophy of the smooth muscles in the tunica media of the blood vessels of lung, and it will lead to pulmonary vasoconstriction. Further, it will lead to pulmonary hypertension. That will increase the pressure in the lungs, increase the pressure in the pulmonary trunk, and now there is more pressure in the pulmonary trunk than aorta. So there will be sound reversal. Now the blood will flow from pulmonary trunk to aorta. So when there is sound reversal, we call it Eisenmenger syndrome. So Eisenmenger syndrome is seen in ASD, VSD and PDA. It is most commonly seen in case of VSD greater than PDA greater than ASD. So Eisenmenger syndrome, we have discussed it earlier. In case of patent ductus arteriosus, there will be also development of Eisenmenger syndrome in the long run. So what happens due to Eisenmenger syndrome? Now the sound is reversed. Now the deoxygenated blood from the right ventricle will go like this. It will go to pulmonary trunk. It will cross the ductus arteriosus, and deoxygenated blood will go like this, go to the lower part of the body. What happens to oxygenated blood? Oxygenated blood from the right ventricle, it will go via the aorta and it will supply the upper part of the body. Now what happens, the upper part of our body, the head and neck, the arms, upper limb, they are supplied by oxygenated blood, and the lower part of the body, it is supplied by deoxygenated blood. Okay, so upper part of our body is supplied by oxygenated blood and lower part is supplied by deoxygenated blood. So what will lead to differential cyanosis, or differential clubbing can be seen in long run. So differential cyanosis be only seen in the lower part of the body, or clubbing can be only seen in the lower part of the body. So it will lead to differential cyanosis. When the Eisenmenger syndrome is developed, now the deoxygenated blood goes to the lower part of the body and oxygenated blood goes to the upper part of the body. It will lead to development of differential cyanosis. This is an important finding in case of patent ductus arteriosus. Now we'll discuss the management of PDA. So we'll discuss medical management and surgical management. So medical management, as I have told you, prostaglandin is the substance that keeps the ductus arteriosus open. So if you decrease the level of prostaglandins, the ductus arteriosus must close. So it is curative only in case of preterm babies. In case of preterm babies, NSAIDs, they decrease prostaglandin, we can use them. So what are the NSAIDs used in case of PDA? One is ibuprofen and is indomethacin. Ibuprofen is preferred more because due to its less risk of in case of indomethacin there is more risk, and in the ibuprofen there is less risk as compared to indomethacin. So what is the decreased risk in case of ibuprofen? That is nephrotoxicity, no risk of nephrotoxicity, and necrotizing enterocolitis, no risk of necrotizing enterocolitis. So that's why ibuprofen is preferred over indomethacin in case of management of patent ductus arteriosus in preterm babies. Another type of management is supportive management. So this is curative management. Supportive management is in if there is volume overload in the heart and there is congestion in the heart, that will lead to development of congestive heart failure. We can use drug like digoxin or furosemide in treatment of congestive heart failure. If there is, suppose the lung is congested with blood, an extra amount of blood that is coming from left heart to the lungs, it will lead to development of pneumonia in the lungs. So that we can manage that with antibiotic. Now I will discuss about the surgical management. So what are the surgical management? So there are some indications in case of preterm baby not responding to medical management. So in a preterm baby you tried ibuprofen, now it is not responding. Or in case of preterm baby, there is contraindicated to medical management, we can't manage it medically. So in heart case, medical management is avoided. One is platelet count less than 80,000. Another is serum creatinine more than 1.8 milligram per deciliter. Another is any active bleeding. As we know, these NSAIDs, aspirin is an antiplatelet agent. So if the platelet count is already low and we give NSAIDs, so there will be bleeding. That's why we don't use ibuprofen or indomethacin if the platelet count is less than 80,000. I told you there is a risk of nephrotoxicity. Less nephrotoxicity in case of ibuprofen, more nephrotoxicity in case of indomethacin. There is minimal risk of nephrotoxicity also present in case of ibuprofen. So if the serum creatinine is already more than 1.8 milligram per deciliter, we don't use NSAIDs in that case. So these are the contraindications of the medical management. One is less platelet count due to antiplatelet nature of ibuprofen or NSAIDs in general, and serum creatinine is raised, or this depends on active bleeding. So these are the contraindications of medical management. So if you cannot manage it medically, we have to manage it surgically. So in case of all term babies and this case of preterm babies not responding to medical management and there is contraindication to medical management, we can prefer the surgical technique. So what is the technique? That is ligation and percutaneous catheterization. There is ligation and percutaneous catheterization using occluders or coils. There is surgical management is ligation or percutaneous catheterization using occluders or coils. So this is all about patent ductus arteriosus. Now we'll move to another disease that is called coarctation of aorta. So coarctation of aorta, it is in acyanotic congenital heart disease, but here there is no left to right shunt. Before we discussed all the acyanotic congenital heart disease like ASD, VSD and PDA, they have left to right shunt and they are acyanotic congenital heart disease. But in case of coarctation of aorta, it is also a type of acyanotic heart disease called obstructive type of acyanotic heart disease. Here there is no left to right shunt in case of coarctation of aorta. So what happens? So this is the defect. You can see this is the defect. This is the constriction or coarctation. You can see. So what is the most common location where the coarctation or constriction of the aorta happens? It is juxtaductal. Juxtaductal or near the ductus arteriosus. So this is here ductus arteriosus is present, connects aorta to the pulmonary trunk. So near the ductus arteriosus there will be coarctation of aorta. So based on the severity of narrowing of aorta, we can divide it into two types. One is almost complete narrowing, that is very uncommon, that is called near complete narrowing. Another is partial narrowing. So in case of near complete narrowing, I told you it is very uncommon and partial narrowing is most common. So if there is near complete narrowing, then there will be very decreased blood flow, severely restricted blood flow to the lower part of the body. It can lead to shock in neonates. So there is severely decreased blood flow, it can lead to shock in neonate. In case of partially decreased or partially narrowing, there will be partially decreased blood flow, decreased blood flow to descending aorta. When there is decreased blood flow to the descending aorta, there will be decreased blood flow to lower limbs also. When there is decreased blood flow to lower limbs, then what will lead to? It will lead to claudication pain in the lower limb. Another is feeble femoral pulses and radiofemoral delay. So what is the condition in which you see radiofemoral delay? Answer is coarctation of aorta. The pulse is felt earlier in the radial artery, same pulse will be felt some time after in the femoral artery. So that is called radiofemoral delay. In normal person there is no radioradial or radiofemoral delay. In case of Takayasu-Arteritis, if the subclavian artery is involved, right side subclavian artery suppose involved, there will be radioradial delay in pulse in the right side of radial artery as compared to the left side. That is called radioradial delay. Now it is called radiofemoral delay. The pulse is felt fast in the radial artery. After some time, the same pulse will be felt on femoral artery. That is called radiofemoral delay or feeble decreased pulse in the femoral artery. So it is a characteristics of coarctation of aorta. And if there is decreased blood flow to kidney, suppose there is decreased kidney perfusion, if the blood flow to kidney is decreased, it can release renin further activate the RAS system. When the RAS system is activated, it can also lead to hypertension. So here when there is partial closure, then the resistance here is increased. It can also lead to hypertension due to increased resistance in this place. Another thing is that when the RAS is again activated, it can also lead to hypertension. So hypertension is the most common presentation in case of coarctation of aorta. If the child presenting with hypertension, you can rule out pheochromocytoma, then most probably the cause can be coarctation of aorta. So it can lead to present with hypertension. So hypertension can lead to hypertensive encephalopathy, and can be present also with seizures. So hypertension is a common manifestation in case of coarctation of aorta. And here the main thing is we have feeble femoral pulses, radiofemoral delay, and now we'll discuss other findings in case of coarctation of aorta. So in older children, suppose the children more than 10 years, there will be compensatory change in case. So when there is compensatory change, there will lead to collateral formation. When there is collateral formation, what will be collateral formation? The blood is diverted to intercostal arteries. When the blood is diverted to intercostal arteries, now the intercostal artery will be dilated and tortuous. When the after long time, when there will be compensation, the blood, there will be collateral formation, and more blood will be diverted to the intercostal arteries. When the intercostal arteries become dilated and tortuous, they will put pressure on the lower border of the rib. That will lead to inferior rib notching. You can see that all in X-ray. So here you can see figure of 3 appearance. So figure of 3 appearance or 3 sign, it is seen here. You can see figure of 3 sign. It is the coarctation or constriction in the aorta. So figure of 3 sign you can see here. This is the stenosis, pre-stenotic, post-stenotic area. This is the junction, the part where the artery is stenosed or there is coarctation. So this is 3 sign. It is seen in case of coarctation of aorta. Another thing is that there is, I told you, inferior rib notching. Here you can see there is some abnormality in this part of the rib, some abnormality in this part of the rib also. The rib, lower border of the rib is not clearly visible. That is called inferior rib notching. Here you can also see that thing, same thing also. Here the same thing also can be seen here. So this is called inferior rib notching due to formation of collateral or dilated tortuous intercostal arteries. Here you can see here is a classical. You can see this is classical, this is also classical, this is also here you can see inferior rib notching, and figure 3 sign it's seen in. And these are the X-ray findings in case of coarctation of aorta. So what is the treatment here? Treatment is balloon dilatation of coarctation plus or minus stenting. So this is all about coarctation of aorta. We have discussed 2 diseases today. First is we have discussed about patent ductus arteriosus and coarctation of aorta. So both are acyanotic congenital heart disease. In case of patent ductus arteriosus, there is present of left to right shunt, but in case of coarctation of aorta, there is no shunt, only obstruction or coarctation. So what are the findings? You can hear in case of patent ductus arteriosus, murmur is classical, machinery murmur, and it can develop Eisenmenger syndrome. You know all that things: pulmonary hypertension, pneumonia, differential cyanosis or differential clotting can develop in the long run. So manage with NSAIDs, medical management, surgical management, ligation, and coarctation of aorta. Pulse of femoral artery is heard later than felt later than the radial artery, that is radiofemoral delay. And X-ray we can see figure of 3 sign and inferior rib notching.